Good afternoon. My name is Al Whitaker, and I am the Director of Mission Delivery for the American Diabetes Association. There's a buzz going around town in the city of Brockton about an initiative called Brockton Knocks Down Diabetes. This is a week-long celebration and appreciation of what is happening in our community around diabetes. It will be a kickoff beginning on June 14th at the Shaw Center. This will be a great initiative where there'll be free cooking demonstrations, physical activity, screenings, the whole kit and caboodle. And it will culminate on June 21st with a festival as well as a walk. We're excited about this because in this community, diabetes is something that is extremely prevalent. And we want to be in the forefront, able and willing to address this epidemic and make a difference for this community. So today we have a great panel of experts and those that can really share with you some of the dynamics and what is happening around with diabetes. So I'm going to have the panel introduce themselves.
Hello, I am Dr. Katia Cordy, primary care physician at Signature Medical Group.
Hi, my name is Julie Lom. I'm a diabetes educator at the Brockton Visiting Nurse Association.
Hi, I'm Nathan Lom, and I'm a person living with type 1 diabetes.
My name is Curly Bollier, and I'm living with type 2 diabetes.
We're now going to have a few questions from our audience, and they're going to ask some specific questions around diabetes, and maybe we can just get some good answers.
Hello, my name is Yvonne, and I have type 2 diabetes. I have a question for Dr. Corty. Are there any other complications that result from diabetes?
Yes, absolutely. There are several several complications secondary to type 2 diabetes. To start with, I can tell you about a big one that we call atherosclerosis, but the meaning is that it's fat, blood clots and some fibrous tissue deposition in your vessel, and that is going to give you some blockage of blood flow, and you could end up having problem in your heart like a myocardial infarction, as everybody calls that as a heart attack. You can also have a stroke secondary to that, and you could have also a problem in the circulation of your legs. Other problems very well known by people is diabetes retinopathy. That means it's damage of the retina in your eye, and it's very important for you to follow up with the ophthalmologist at least every year. Make sure you do the regular screening because this is a major cause of blindness in patients with diabetes, and the studies have shown that laser treatment has been effective in preventing blindness. Other complication we call diabetes nephropathy, and that is pretty much damage of the kidney secondary to diabetes, and the way I present my patients that diabetes now is affecting your kidney. The function of the kidney is filtration. So if you think that your kidney is damaged, you're going to have accumulations of lots of water and toxic metabolites in your body. So that's going to pretty much affect several organs, as your heart, as your lungs, your liver, and so on. You can have like a minor the beginning stage of that would be just a little bit of leakage of protein in the urine, and that can be actually controlled if you take your medications, regularly. But then over years, and especially if the diabetes is not well controlled, you can have end-stage liver disease and dialysis. Actually, the leading cause of end-stage renal disease and dialysis in the United States is diabetes and high blood pressure. And the last complication that I'm going to mention here is diabetic neuropathy, that, as the name say, is nerve damage by uncontrolled diabetes. And every organ and tissue in our body is supplied by nerves. So if you think this way, neuropathy can actually affect any part of your body. And we all know about the sensation deficit that patients with diabetes they have, and that impaired sensation they can They can get in accidents. They can, hit their extremities without noticing, and that develops a wound. And diabetic patients, they have also issue with healing. So because the healing is impaired, this wound can infect and can later develop necrosis, and this leads to, unfortunately, like amputations that we hear about. But neuropathy is actually more than that. You can also have weakness, of your extremities because the nerve is damaged. You can have issues with your balance. You can have issues with your urinary system, like urinary incontinence. You can have issues with your gastrointestinal system, like gastroparesis. The stomach works very slow. You can have sexual dysfunction, and so on. It's many complications from uncontrolled diabetes.
Thank you.
You're welcome.
Dr. Court, I think that which really goes to show you how important or how much damage diabetes can do. One of the questions I would like to ask is maybe to clarify for some of the viewers, what is the difference between an ophthalmologist and an optometrist? Because I think sometimes community residents get confused about that.
Well, I usually refer my patients to the ophthalmologist because the ophthalmologist is MD, it's a medical doctor, it's a physician that in case the patient has any other medical issue to the eye that actually needs a medical treatment or any intervention, this provider would be the one that would be able to prescribe medications or do an intervention. And in the case of diabetic patients, because of not only for diabetic retinopathy, but diabetics, they also have a higher incidence of macular degeneration, cataract, glaucoma. So they really need a very comprehensive eye exam.
Thank you. Next question.
Hello. I have a question for Nathan. For one living with type 1 diabetes, would you recommend the pump? What is the benefits or challenges?
I myself have been using the pump since 4th grade, so about 11 years now. And it's definitely got some benefits, and there's also definitely some drawbacks. One of the drawbacks, one of the major ones actually that catches a lot of people, is that you got to keep in mind there's always going to be a piece of medical equipment attached to your body, and it's going to go everywhere that you go. What actually won me over and helped me decide to get the insulin pump was the fact that I only need 1 shot every 3 days as opposed to 3 to 5 shots every single day. And it's important that you regularly monitor your blood glucose level, because if your pump site has failed or if there's any issues with the pump site, you can get ketones and end up very sick in the hospital, and it could all be fixed just by simply changing your pump site. And so there's really all sorts of different choices.
Okay, thank you.
Next question.
Thank you. This question is for Julie. I see you're a nurse at the Brockton Visiting Nurse Association, and your title is Certified Diabetes Educator. Would you mind explaining to us what a Certified Diabetes Educator does?
Sure, that's a great question. So a Certified Diabetes Educator, also known as a CDE, is a healthcare professional who has pursued extra training and has passed a pretty rigorous exam specializing in the field of diabetes self-management education. So a CDE has the training and the knowledge to work with clients that are affected by diabetes or affected by pre-diabetes, and what we help them do is to achieve very individualized specific goals for them to optimize their health long term. Oftentimes when a person that has diabetes or pre-diabetes sees their particular healthcare provider, they're really only seeing that person for very short periods of time throughout the year. You may have a total of 2 to 4 visits in the course of a year, and those visits oftentimes are very time constrained. If the certified diabetes educator becomes part of your healthcare team, you have another person in your corner that can spend some extra time and give you the coaching and the teaching that you need to manage this diabetes, which is a chronic disease 24/7, manage this diabetes in the long term and hopefully achieve the best outcomes for you.
Thank you very much.
You're welcome.
Next question.
Hello, this question is for Curly. What has been your biggest struggle living with diabetes?
My biggest struggle has been not doing what I need to do to take care of my diabetes, eating the wrong foods and too much of the wrong things, and not checking my blood sugars when I should. And that's one of my failures, but now I'm learning to monitor my blood and to eat things that I should eat to help me for my blood sugars to come down. So they did. Now, at one point it was a 10. I had an A1C of 10. Now it's down to 6.3.
That's great.
Because I'm managing my diabetes. But I still have a ways to go, but I'm on the right track.
Good job,
Yeah.
thank you.
Excellent job.
Next question.
Hi, this question is for Nathan, and as an individual living with type 1 diabetes, I assume that you've been to many doctor's appointments. With all of that being said, what would you want your healthcare provider to know about life with diabetes?
I think the most important thing for the healthcare provider to keep in mind is that I do have a life outside of those office visits, that I have an everyday schedule of just anything that comes. I like to hang out with my friends, I work, I'm going to school, and diabetes just isn't always the main thing on my mind. As Curly was saying earlier, she's been working towards a better A1C. I don't think there's a single diabetic that I know, or a single person with diabetes that I know that isn't trying to better themselves, or trying to just get a little bit better. And it's not that we're deliberately eating the wrong foods, or deliberately eating too much of the wrong foods, or purposely forgetting to check your blood sugar. It's just not like that. It's just not the main thing on your mind, and I think that that's very important to keep in mind.
Great, thank you so much.
Just to clarify, I think we're talking about A1C, and people may be wondering, well, what is an A1C? So an A1C basically is a blood test that will measure, it takes an average of your blood over a 3-month period of time. The recommendation is that it be 7 or under if you're living with diabetes. For someone who doesn't have diabetes, it's under 5.7. So when you hear these numbers like 10, a 6 is very good. So just to give people an idea of what an A1C is.
I have something to add in that respect as well. So I, as a healthcare provider, and also, a mom of one of my kids that is living with type 1 diabetes, I think it's important for the healthcare provider to realize that our patients are much more than just numbers. And I think that's what Nathan and Curly were trying to bring across as well, is that there's a whole life that you're trying to manage, just like everyone else is trying to manage, and on top of that, you have to deal with diabetes 24/7 that just is a chronic illness and never ever takes a day off. So I think it's important not to use the term non-compliant. I still hear that term, and I think that it's wrong. And I think it's wrong because I work with so many patients that do have diabetes, and I live with, my son, and I see the struggles day to day. And it's not at all that the person is purposely trying to be non-compliant. They're just trying to juggle so much in their life, and I think that's important for the healthcare provider to realize.
That's a very good point. Thank you. Next question.
Hi, my name is Martha. I have a question for Julie. I was just given a referral to see a certified diabetes educator. What should I expect now?
That's a great question, Martha. First off, congratulations, because there's not enough people, I think, that are given referrals to see certified diabetes educators. So I'm glad that you are one of them. So the process is actually going to be different for everybody. There's no set process. But typically what happens is that your healthcare provider gave you a referral to see a specific diabetes educator. So you will get a phone call probably from that CDE, and he or she will set up a one-on-one assessment appointment with you to go over sort of like your health history, what your goals are, where your struggles are, and some basic diabetes education. Once that assessment takes place, we actually together, you and I would work together to come up with a specific education plan that is what Martha wants to accomplish. From there, you would be either sent to group diabetes education classes or individual teaching based upon what your needs are. Wherever, whether it's group or it's individual education, we would touch on subjects like monitoring your blood sugars, recognizing patterns, taking medications, exercise, nutrition, risk reduction, healthy coping, everything and anything that is needed to help Martha deal with her diabetes on a successful way for the rest of her life. So congratulations again. I'm glad that you were referred.
Thank you.
Sure.
And if you were referred to Judy, she's excellent. She's the best.
Thank you.
I am Mohammed Sheikh. I have got a question. What are some of the risk factors associated with the diabetes? It is for Dr. Corti.
Risk factors associated to diabetes are, number one, I would start with family history. That is, very significant. You see patients who have one first-degree relative with diabetes. This person has 2 to 3 times higher chance of developing diabetes, and people who have 2 relatives, one maternal and one paternal, with diabetes in the family, they have 5 to 6 times higher chance of developing diabetes. So this is something that you can actually not change, but other risk factors you can change. Let's say obesity. We have seen studies that people who have moderate obesity, that we say when the BMR is 35 or more, these people, they have so much higher chance of developing diabetes compared to someone with the normal weight. Type of body fat, for example. People who have the male type obesity, that means it's when the fat is more in the abdomen instead of the female type obesity that is distributed in the thigh, in the buttock. So these people who have, we assess that by checking the waist circumference, and then these people, they also have a higher chance of developing diabetes. And people who don't do exercise, people who are sedentary, they have a higher chance, very likely because these people are more prone to have weight gain. Type of diet that you may have, people who eat diet that's high in sugar, especially beverage with high sugar. People who eat lots of red meat or processed meat, they also have a higher chance of diabetes. And less commonly, but sometimes some medications can, give you a higher risk of developing diabetes as well. These are the major ones.
Thank you.
You're welcome.
I have a question for Carly. A few minutes ago, we heard that you were saying about how did you struggle with diabetes. What would you tell your friend or a loved one, or what do you recommend who's listening us right now about how to tell a friend or a loved one in order to get best support from them?
Well, I like to tell them, don't police me, but don't encourage me to eat things that I shouldn't have, and respect that. And when they're in my company, if you want to eat those things, fine, but don't try to encourage me to eat things so that I can fall off the wagon, and then I just tell them, I love you, and I hear what you're saying, but please, Don't encourage me to do what's wrong. If you're going to do something, encourage me to do what's right. Be a support team for me instead of being against me. So,
Thank you so much.
okay.
Hello. My mom is a senior citizen, and she was recently diagnosed with diabetes. And my family and I are really concerned for her health, and we're also really concerned because we've heard that diabetes is pretty expensive. So I was just wondering what we should look for. Like, what are the most important options in looking for coverage through insurance?
Hi, my name is Eileen Isherwood. I'm the marketing person for Senior Whole Health. Senior Whole Health, for those of you who don't know, it's a health plan, comprehensive health plan for low-income seniors. And we have some of our folks are in the audience today, so thank you for coming. Senior Whole Health, actually, we want to keep people healthy, so we provide comprehensive coverage for diabetes management, which includes screening, it includes diabetic supplies, insulin. We also cover diabetic shoes. I believe it's one pair every 12-month period for our folks where their primary care doctor advises that. So we work very closely with our members' primary care physicians and our nurse care managers that are assigned to each of our patients. So we want to keep people healthy and help them manage this disease and stay out of the hospital, basically. And also, I just want to add, too, that there are no copays or costs associated with our plan. We cover everything, and there's zero copays for our members. Thank you.
Well, I have a few questions. The first one is for Dr. Corte. Will I need to stay on my diabetes medicine for the rest of my life?
I would say yes, you probably will, but I think the priority here is to manage your condition, and my strong recommendation for any patient with diabetes is intensive lifestyle changes. I mean, diet, exercise, and weight loss with that, because when you take this seriously, you can actually be able to reduce the number of medications you take or reduce the need of medication. And in some cases, you actually can, not need medication anymore. These are a few cases, but yeah, it's possible. When I talk about lifestyle modification, just to be more specific, diet, we have great evidence with the Mediterranean diet. That means a diet that is high in fruit and vegetables, high in whole grain, olive oil, low in red meat or any processed meat. And exercise, what we have seen in studies is if someone is able to exercise for 30 minutes 5 times a week, that gives you 150 minutes a week. That has shown to be very significant in the management of diabetes. And moderate level of exercise, we mean an exercise that the patient would be not able to sustain a conversation and would have some level of sweat. I mean, moderate exercise, just to give you more idea. For some people, they can think that walking a dog outside and talking on the telephone with a friend could mean exercise, but it's not actually what we are looking for. And weight loss, the goal, I would say, 5 to 10% of fatty reduction. So if you take, all these measures seriously, it's definitely going to impact in the treatment of your diabetes.
Thank you.
I think also, Al, if I may add to that, is that it is true, like the long-term goal, as Dr. Court says, is that we're aiming for 30 minutes, 5 days a week. But what I stress to my clients is that we really want you to do just a little bit more today than what you did yesterday. Because I think we all fully realize that nobody's going to go from being very sedentary and sitting on a sofa to 30 minutes, 5 days a week. So just a little bit more than what you're doing today will be enough. So I think that's important to stress as well, and then slowly working up.
So I guess it's good to take baby steps and
Absolutely.
work your way up, which is probably the better route. Anyway, for you, Julie, what is the difference between type 1 and type 2 diabetes? I think that's a big mystery to a lot of people.
Yeah, it is. And what I want to stress is that the end result of poorly controlled type 1 diabetes or type 2 diabetes is the same. We end up with the same chronic complications that Dr. Court had spoken about earlier. But basically what you need to know is that type 1 diabetes is a autoimmune disease. And basically what that means is that the person's, to simplify it, the person's white blood cells that attack and kill bacteria and foreign material in a person's body, for some reason, attack and kill off the cells in the pancreas that are responsible for making insulin. And unfortunately, those cells do not regenerate. So in a person with type 1, typically people are diagnosed in childhood, and it does result in an almost total destruction of beta cells, of insulin-producing cells. In a person with type 2 diabetes, it's really sort of 3 different things that go wrong, but the most important one is what we call insulin resistance. And insulin resistance basically makes it very difficult for insulin to facilitate the movement of sugar from the bloodstream into the cells of the body, which is where they belong for energy. And what we know about insulin resistance is that the heavier a person is, the more weight we carry on our body, the greater the degree of insulin resistance. And also the more sedentary that we are, the greater that degree of insulin resistance. So those are the 2 differences between the 2, but again, it's not that one is worse than the other. I think I get asked that question a lot as well, which is worse. One is not worse than the other. They can both end up with the same devastating complications if they're poorly controlled.
Well, thank you. I mean, that really kind of puts it in perspective, because this is something I hear all the time. There's a big difference between 1 and 2, and I think you really brought it home, so thank you for that. Well, I'd like to thank the panel today and the audience for being here. I just want to reiterate about Brockton Knocks Down Diabetes. This is a great event. I mean, when you look in terms of who are the partners, we have community partners, there are community health centers, there are actually health entities, corporations. So this is something that is truly for the community. And we encourage you to come out and participate in these free, operative word, free activities. If you want more information, you can definitely go to the website, which is www.harborone.com/diabetes. And you can also go to our Facebook page at Brockton Knocks Down Diabetes/Facebook.com. So we thank you and hope that you have a great evening. And remember, you can make a change when it comes to diabetes. Thank you.